Hello and welcome to another in this series of NR Times Roundtable discussions. And today we're focusing on the outlook for community care and support, and particularly supply versus demand, a really specific and clearly crucial topic. We've got a fabulous group of panelists with us today who are going to address that topic and give us their thoughts and experience and views about the current state of play and, of course, the future as well. So I'd like to start by asking all of our panelists to introduce themselves and say a few words about themselves, their organisations, and, of course, their areas of specific interest. If I could start with you, Sarah, could you introduce yourself, please? I think you're still on mute, Sarah.
Good morning. My name is Sarah Hayes. I'm a lead occupational therapist for St Andrews Healthcare. Within St Andrews, we have got 5 inpatient wards and 2 community houses for those that have had acquired brain injury. Our patients come into us most often because community placements have broken down, or directly from other units where they have been unable to be managed within those. So they come with quite high levels of behaviours that challenge, and through their time with us work through from being on a very acute ward with high acuity through to potentially having the opportunity to go back into the community. The passion that I have currently relates to understanding more of the impact that the Mental Health Act and the Mental Capacity Act have on those that we care for within brain injury, and how in actual fact the platform of the Mental Health Act can actually really promote our rehabilitation for those who have a very severe brain injury, and then to be able to obviously see them forward through the rest of their rehabilitation. And if you like, I think that one of the big blockers that we have is where people go from where we are as an inpatient service to actually having access to what they need in the community.
Great, that's excellent. Thank you for that, Sarah. Jane, could I come to you next, please? I think you're still on mute, Jane.
Yep, sorry. My name's Jane Powell. I'm a clinical neuropsychologist by background, and 3 years ago I set up Cognivate, which is a team of therapists from all disciplines who provide community-based rehabilitation for people with acquired brain injury. Our clients are currently adults, although we sometimes work with people who are at the cusp of moving into adulthood. And we cover currently London and downwards towards the south coast, but we're hoping to expand our services in a slightly more northerly direction. The service we set up is based on the team which I founded more years ago than I care to think, back in the 1990s at Homerton Hospital. That was the UK's first interdisciplinary community-based rehab team, which we demonstrated is effective through a randomised controlled trial. And I think that has spawned a lot of growth in community teams across the country within the NHS. There are actually very few teams which provide this privately. So that's a gap that we've moved into. And although most of our clients are funded through medico-legal routes, we also want to make services accessible to people who don't have that kind of funding. So our therapists lead a number of very focused groups addressing different areas of concern after brain injury, which are freely accessible to anybody with a brain injury. And we're really keen to use new technologies to continue developing communications with other healthcare professionals who are involved and making more services available to more people.
Thanks for that, Jane. Pedro.
Good morning, everyone. My name is Pedro Grilo. I'm a consultant clinical psychologist and the head of care at the Richardson Care. So we are based in Northampton and we are a residential service. So we do have 6 care homes and we care for people with brain injury and learning disabilities. But today is more about the brain injury pathway. So the majority of our service users, they come from hospital. We, for example, have service users from St. Andrews that they are on the pathway to come from hospital to the community. We have around 70 beds. We are a residential service, home for life, but we also offer active rehabilitation because our goal is to support the service users to live in the community. We employ a team, an MDT, a multidisciplinary team. We have a neuropsychiatrist, OTs, physios, assistant psychologists, so on and so forth. The majority of our service users, as I said, they come all from acute hospitals, is a step down into the community. And currently, we are thinking, and I think that interlinks with the conversation today, as an organization to provide not residential support, but independent living, because we find quite difficult when the service users reach a point in their rehabilitation that they are safe within the inpatient service or residential service to move back into the community, and we find quite difficult that process. So the organization is thinking about, in fact, explore the opportunity of having supported accommodation in the community. That is us in a nutshell.
Great, thanks for that, Pedro. Natalie.
Good morning, everyone. I'm Natalie MacKenzie. I'm Director at Biz Services. So we provide specialist cognitive rehabilitation assistance working with individuals with acquired brain injury in the community. I set up the organisation, I think 17 years ago. Like Jane was saying, it was years I probably think is yesterday, a very long time ago. So we focus on providing specialist input and high caliber rehab assistance to support clients in the community. Similar to others, we're predominantly within the medico-legal claim framework, but we also do work within statutory provision as well, which comes with other challenges. I also am a trustee at Headway, South East London, North West Kent, so see some of the challenges that come from the charitable sector and being able to provide individuals with support and specialist rehab that can't access it through a claim. We're very much focused on ensuring that there's a high caliber, high standard of individuals that are able to become part of that MDT, working with the clients in the community, have specialist training and knowledge about brain injury and cognition so that clients can increase their independence and function. And we are specialists as well, similar off the back of what Pedro was saying, in independent living trials in the community, putting teams together to support clients to be able to improve that independent living skill and maintain vocational and educational placements. In a nutshell.
Great, thanks, Natalie. Stephanie.
Hello, everyone. I'm Stephanie Fleet. I'm an occupational therapist and I work with Think Therapy First. So Think Therapy First are an occupational therapy company providing high-level rehabilitation, mainly in the medico-legal sector, nationwide throughout the UK and also on the Isle of Man, which is quite exciting. So we are predominantly working with people who have brain injuries and spinal cord injuries, but also complex orthopedic injuries. We're working with them in their home, in their communities, and providing intense rehabilitation to get them as independent as possible and back to living their life, in a nutshell.
Great. Thanks for that, Stephanie. And Maggie, I'm just asking the panelists to say a few words about themselves, their organisations and your areas of specific interest by way of introduction.
Lovely to see everyone today. I had 4 wisdom teeth out on Monday, so I'm a bit swollen, and if I forget a couple of words, it's because of the anaesthetic apparently. But anyway, that's going to be my excuse for the next few days. Well, I'm here for Community Case Management Services. We set that up back in the 1990s. One of the first case managers and still practicing. We have a network of case managers across the United Kingdom. We're registered in Wales as well. We also work quite a bit in Europe. We have people in Poland and Italy and various other countries that we work with. And we've worked with people providing initial rehabilitation services, organising therapy, support workers, right through to working with them 30 years later. We try and give people a life. We do quite a lot of trips abroad and holidays, because when you're case managing people and they've had a traumatic event, they want a normal life, and what do you look forward to in January? I mean, sometimes people say got a little bit of too much of an emphasis on travel, but most of us are looking at booking our summer holiday, aren't we? We're thinking about where are we going to go, what are we going to do? Our clients are no different. So we have a house in France that we have adapted, that we work with. We've done 14 ski trips. I've even taken someone on a ventilator skiing. We go to Africa. We help out in a special needs orphanage. We go on safari. We do whatever we can. People either fund it through their claim, or we raise money so that they can do trips. We do collaborations with charities and work with the Silver Lining a lot. And we've worked with the ski charities and Headway, DSF, anyone we can really, because basically we have clients. We're responsible for giving them a life and getting them to live their best lives. And it's not easy nowadays getting the right staff, but obviously if you're doing positive things and trying to be as positive as possible, that helps with recruitment and retention. That's a little summary.
Great, thanks, Maggie. I could see everybody wincing as you described your dental treatment, so it's great to have you with us. Thank you for battling through. The focus today is very much with reference to talking about positive developments, but I think we should start by talking about the current challenges of meeting the needs of community rehab and care, and then we can move the discussion on to how we're overcoming those challenges and going beyond that. Sarah, can I start with you again, and we'll work through all the panelists and just get some thoughts on the challenges of meeting those needs? I think you're on mute again, Sarah.
Being an inpatient setting, we need to do a lot of work with case managers, with the ICBs, the commissioning services. So when people are ready to move on to us, we're a national service, so we need to speak to very many different sectors to be able to make that transition from here into the community. Now, what we offer here is there are a number of what we would call sheltered flats that are within a ward, where we do give people the opportunity to, as much as they are able to, fully engage in caring for themselves and everyday living. But we know in actual fact the most important thing, or the next stage, is to take somebody who has been here, who's very used to having the whole milieu therapy that is around them, the therapy that's actually enabling them to function extraordinarily well, to be able to take that and then put that into the community is something that requires a lot of liaising. And what we find is the community can't always provide, for obvious reasons, what we have here. And then you have people going from the inpatient setting into the community, into unknown environments, unknown communities, and it's how we work with community services to enable their rehabilitation to carry on. And we also find that related to costing of services, that can in and of itself be a blocker to people actually being ready to leave inpatient services to be able to go into the community. So I don't think that we can or we need to recognise how much when patients are, when our here, what we need to recognise is that when people are within a inpatient service, they, despite the fact that we take them on quite an extensive rehabilitation programme, they still have the structure, the support, the mentoring, the coaching, and the reflection that they have here, to then be able to take them and to take them into a home that may be safely staffed, is an area where we find that people really do struggle. And we've already made reference to the fact that we need to have the staff there, the transdisciplinary working, to be able to continue that success in the community.
Thanks for that, Sarah. Jane, what are your reflections on the current challenges of meeting those needs?
Well, I think this is a very logical follow-on from what Sarah was talking about, the transition from inpatient or residential services to the community. We know that for complex patients, especially, it's really important that care is joined up at all levels. So we provide therapies. It's really essential that the OT is talking to the speech therapist, is talking to the physio, is talking to the neuropsychologist. You have to have that range of perspectives brought together in a meaningful way if people are going to optimize the continuation of their rehabilitation journey successfully and get to a point where they can fly on their own, we hope. And it's also really essential when clients are at that level of severity that they need support within the home, that rehab assistant support or support worker input is skilled, knowledgeable, and again, really well connected with therapy input. And I'm sure Natalie will talk a little bit about that when we come to her as well. So I think some of the barriers at the moment for many people, especially those who don't have the luxury, let's say, of funding through medico-legal systems, is that although there is some really good provision within the NHS, it's really patchy. It's patchy geographically. It's often very limited in terms of the duration of input which can be provided. And I think one of the biggest issues is the availability and training of sufficient therapists in particular disciplines to be able to be appointed to those positions. So we're very aware that in our area, some of our clients have had access to NHS services, but there's often no neuropsychologist or there's no speech and language therapist because there are simply not enough of those disciplines currently being trained and in the pipeline. So I think that is really one of the major challenges, along with often very long waiting lists before people can be seen, in which case they may begin to lose some of the gains which they've made in previous residential settings, which is such a short-term, that lack of immediate funding is a real problem because of the loss that it creates, really. I think that, and also, which I know will be picked up later, the difficulty in finding really good support workers who have got that experience and expertise, who are able to practice with clients the particular techniques and strategies and so on that are being recommended by therapists. A couple of sessions a week of a therapy is great, but it really needs that ongoing practice for the gains to be maximally realised. Thank you.
Great, Jane, that's really helpful. I'm conscious that as we go around the panel, there'll be a diminishing number of themes that you can pick on. So feel free maybe just to supplement some of those themes. It's just to stretch out that sense of where the challenges lie so we can then move on to a discussion about how we overcome them and some of the innovation that's driving that. Pedro, can I come to you next and just remind everybody, if we all mute when we're not speaking, that would be great, just so we can hear the speakers.
I thank you, Alistair. I echo everything that Sarah and Jane said. Richardson, as a residential service, we offer an MDT, so we are lucky in the sense that we have the professionals and we offer training to the healthcare assistants or support workers from a neurobehavioral point of view in terms of supporting our service users, and our service is psychology-led. The main challenge with us is pretty much related with funding, as the changes of the change of needs of the service users sometimes at a very superficial level indicate that they are ready to move on. But in fact, what happens is the scaffolding of everyone around the service users, in fact, support them. And as soon as the service use of the person is stable, there are discussions about reducing funding, which would impact, as Jane was saying, the number of therapy hours that the service user is offered. And that would impact on their rehabilitation. The other issue that we face is that our service cares for people with brain injury, but the majority of our service users, they do have premorbid conditions, being learning disabilities or mental health difficulties. As soon as we start seeing a recovery from the brain injury, those themes start to emerge. And as a service that is geared up to support people with brain injury, we then find ourselves in positions where we have to care for people presenting chronic mental health difficulties. Our difficulties then are to liaise with the NHS. I could spend the whole morning talking about cases where community services, particularly from the NHS, were not rapid enough in offering support to us. And what happens is that there is a deterioration on the service user, and then the person is readmitted back to hospital. And when I talk hospital, is about a person possibly being cared under the Mental Health Act, and so on and so forth. So at this moment in time, particularly in our geographical area, that is in fact the main challenge, is the lack I don't want to say lack, I already said, but the limited support that community services through the NHS, particularly mental health and learning disabilities team, and we understand all the pressures within the NHS. I myself also work for the NHS. That is one of the issues that we have, the liaison between our services and the NHS and the support to the service users, impacting then on the service users likely having relapses and having to be readmitted to hospital.
Thanks, Pedro. I'm sure we'll come back to that theme of the links between public and private sector and how all the services join up effectively. Natalie, can I come to you next, please?
Sorry, I am going to flip back to the other theme, though, about the need for the high caliber staff. I think that's where we come in terms of the challenges that we face, is what both Sarah and Jane were saying. When we can get involved in the transitionary process, we know that it works better. If we can come in to these settings and work on a graded return to the community, we know it works better. But the challenge with that is that you can't have people in your settings part-time. It's difficult to make, because you need to fill more places. So we don't actually have the availability to do that graded transition. But years ago, I remember when we would work with the likes of Haberdasher's House and go in, and our team would be in there and we'd have a lovely seamless transition into the community, which again, we know works, but it's just so difficult for us to be able to do that. And we do have some pushback, to be honest, sometimes going into other settings where an external provider is coming in, and we shouldn't have to have that barrier. But going back to the issue with just staffing, and I know there's a whole other webinar on it, but being able to get staff that understand the high needs of these clients is the hardest part. And as Pedro was saying, with people coming out into the community perhaps sooner than they were doing years ago, because there isn't enough sort of settings for them to transition into, we're having to deal with much more complex need, mental health need, neurobehavioral within the community. So that caliber of staff has to be even higher than it did used to be in terms of just cognitive rehabilitation. But for us, the challenge is the speed at which we can find those individuals. So we only employ psychology graduates who have some sort of experience within mental health settings or learning disability or brain injury, and we train them in brain injury and cognition and cognitive rehabilitation. But the speed of which we can do that, because we match, and it's not just to say we've got an RA that lives in Ipswich, therefore that person works with clients in Ipswich. They have to be matched carefully to that client and work within that family unit and match with the MDT. That takes time. And if we are having a referral that's coming, you're going to be discharged in 2 weeks, we need a whole ILT package put together. That takes time, just even things like the checks and the references. And we have a big bank of RAs, but they might not be the right match and the right experience for those clients. What I found recently, the last few years, is that the needs of the clients are much more specific than they used to be. I mean, I joke sometimes that we may be asked for a psychology graduate who is 32-year-old male. We know there's not a lot of male psychology graduates anymore, who is a lover of Taekwondo and speaks Nepalese, say, trying to fix all of those small things which are important to the clients. We have one at the moment who will only have an RA with experience with a psychology degree who likes coffee and likes going out on a bike. Sounds simple, but that funnel of people that are able to work with the individuals is getting smaller and smaller and smaller. And then on top of that, once they're in, how well do they integrate within the MDT and the IDT, and what happens if the client, because we know this happens a lot, doesn't have that rapport or isn't finding that it's working very well with the RA, and we need to do the whole process again. Just the practicalities is really challenging for us. And then retaining those staff as well. Great that they come with a psychology background, but we know they want to go on and become clinical psychologists. And that's, for me, on a personal level, something I'm really passionate about. I want to create a new future of neuropsychologists who have done the work in the community on the ground, that understand the challenges, so that when they're off as neuropsychologists, they understand the need for that.
Great, thanks, Natalie. And I think there probably is a separate discussion on that. It would be fascinating to think about how you could bring together government, health services and academia, further and higher education, to make sure there is a steady stream of the right kind of talent and skills coming through into the sector. I think that would be a really interesting discussion. Stephanie, can I come to you next, please?
Hello. So what we're doing at Think Therapy First is filling in the gap of the community rehabilitation. So we all know that people, when they're in hospital and they've got these serious life-changing injuries, they want to get home. They've generally been in hospital for a long time, desperate to get home. And so the therapy in hospital naturally is focused, I've done it myself, you focus on what they need to be able to do to get home with the minimum care that you can, with the community teams picking up the rehab then in their home. But what we're seeing is that community rehab isn't taking place. And what is taking place is focusing on compensatory and adaptive techniques and not on restorative. So what that risking is creating more of a care need. So more people needing more care visits and longer care, rather than being able to optimize what they've got and what they're going to be able to get to reduce that. So that's the gap that we're filling. And I'm seeing more and more of really young people in their 30s and 40s going into nursing homes, because that's the only beds that are available. One gentleman I know of is currently stuck on a dementia ward in a nursing home and having horrendous time, and just not able to get home for various reasons, and also not getting the rehabilitation in those settings, so completely stuck. So we're filling that gap with intensive occupational therapy, working with statutory services, bringing in more of the other professions, the neuropsychology, physiotherapy, all those types of things. And we're able to then work with all of the professions and practice all the skills that they're learning in those other sessions into the environments where they need to be. So they really are getting those transferable skills. So it really is old school, proper occupational therapy, and that's reducing care needs. So I did a bit of an audit of some of the clients that we've seen. So I had a quick look at, I think it's 501 I did a screenshot of, and out of those, there's only a handful that needed ongoing care after their intensive rehabilitation. I think that's the way forward. We can't influence what government, unfortunately, are deciding. We all know that there's some difficult decisions coming ahead with that. There's a lack of care. We all know that. And I feel like very strongly that we can't influence that. But what we can influence is the quality of the rehabilitation that's going on in the community to reduce those ongoing care needs. And I could talk about that forever. But that's the main things at the moment.
Well, we might come back to you, Stephanie, so that you can talk a little bit more about that. But Maggie, final thoughts on the challenges that you and your organisations face. I think you're still on mute.
I was just saying there's so much to say, really. Case management started so that people could be discharged in a joined up way, so that there would be management on discharge and ongoing. And that's what we've all tried to do. I totally echo what Jane is saying. I find one of the major issues is that there's therapy when people come out. They don't have the rehab assistant, which should be introduced from day one with the therapy. And then they have this big thing, they don't want care. Well, they don't need care. But if you've got memory problems, you can't remember the therapy you've been to. So you've got to have a rehab assistant that's going to work on it. And to me, that just makes sense. And I don't understand why we didn't do more of it in the past. Yes, it's difficult to find staff. We're finding we actually partner with colleges. We have people coming from their courses and coming and working for us as rehab assistants, support workers, and depending where they're coming from and what course they've done. That works really well. I think it's frightening at the moment. We've been going for a long time, as I've said. And so of our settled cases in the medico-legal world, only 50% have got enough money. 50% of our clients are funded by IHB and social services in the longer term. And there are a lot of issues there, but you know what? You can get funding. We've got case management funded. I've got care, really high quality ongoing care, because actually if you do it on a direct hire and you're paying good rates of pay, £18-20 an hour, that means that you're saving on long-term agency costs of £35-40 an hour. So it's something we've had to fight very hard with the government to get the rates of pay for people, because you know, they don't, the local IHB, no, they don't want to pay it because you know, it might affect all the rest of their care packages around, but we have to make special cases. We've had discharges from St Andrews, and I know all the issues of trying to get the right people for people with behaviour problems who need continuity. And yeah, it's hard at the moment, and it's costing money. But I think we just have to keep at it. And I think we've had to rethink the role of the support worker. It's not a low-paid job. They are the people at the front of, at the foreface of dealing with these clients. People don't want to spend money keeping them in hospital at thousands of pounds a week. Therefore, if they're going to come home, they're going to have to invest more in staff. And that's what we're having to do. And I think we're seeing it. We are getting slowly the IHBs and people to accept it, but it's taken time.
Great, thanks, Maggie. That's a great link there into talking about the innovative ways that organisations are overcoming those challenges, and in doing so, continuing to improve and develop services and care. You gave some of those examples there, Maggie. Can I just open up the discussion and invite any of our panellists to talk a little bit about the innovative ways in which you're overcoming some of those challenges? And using the work that you're doing, not just to work around the challenges, but to continue to improve services.
Can I come in there? I think one of the silver linings, if you like, of COVID was that everybody was on a crash course on digital technologies. So it's become increasingly easy. There are fewer barriers to being able to communicate internally, within teams, across teams, with other professions, and most importantly, with clients. And that's sometimes through Zoom or other video platforms, but it's also through a real acceleration in the development of some fantastic apps and other technologies which can simplify for clients the process of rehabilitation by bringing information together in very straightforward, visible, tailored to particular client needs. So our service, Cognivate, we employ a team of therapists directly, and then we have a network of associates who work with us so that we can put together a team of different, the right combination of therapists for a particular client, as far as possible in a geographical area which doesn't involve too much travel for anybody. But we're able to make it more now than ever in the past. We're able to make that integrated treatment planning and delivery effective because we can use things like Google Chat. We put together a little chat room for each client so the therapists can keep in touch on a daily basis. What happened in their session? What does that mean for the next person going in? We're able to quickly liaise with clients and deal with practical issues which may be coming up and compromising their ability to be present for an assessment. It can be overwhelming for some people to have lots of therapists physically present, but in some cases it may be possible for some of that therapy to be delivered remotely, which is cost effective and often just as clinically useful, not for all clients, but for some. So I think the increasing take-up of existing digital tools is really helpful. That interface between what support workers and rehab assistants are able to deliver within home settings and an immediate contact with the qualified professionals who are able to learn from their feedback and provide information to adjust in real time what's happening has incredible potential. And likewise, Maggie and others were talking about the interface with NHS services. It is really, really clunky at the moment. But there is promise there that if we can work with our NHS colleagues and systems to try and overcome some of the institutional barriers and use digital technologies and mechanisms to help with that, it could open up a better collaboration, I think, going forward.
Some great examples there, Jane. Maggie?
Very quickly, just to say that it has been amazing, Jane, doing the feedback with the psychologists online for our staff. They all get, we've got difficult clients. The most important person behaviourally is the neuropsychologist that's going to be working with them. And for them to be able to arrange, for us to be able to organise monthly feedback with the psychologists for each of the staff and to be able to do meetings online has been absolutely mind-changing. It's given us so much more support than we ever had before.
Thanks,
Yeah.
Maggie. Pedro?
Yeah, Maggie, that is, and what Jane and Maggie were saying is quite important. I work also with some cases and medical legal cases and supporting the teams and new technologies. In fact, the length what we can reach and what we can offer, it's absolutely amazing. In our case, and I'm going back to the NHS challenges, the liaison with NHS, I think having meetings, having a partnership, because sometimes there is a bit of a punitive approach when we complain about the NHS not being available, rather than to be more an educative approach in terms of explaining the needs of the service, involving the NHS, local NHS within our service. That liaison might be the way forward. It's quite difficult, it's quite challenging. I would be happy to hear what others have to say about this matter, but that to us as an organization is quite challenging. And the worry that we have, and again, we care for 70 people in residential settings, and what we are noticing, possibly since COVID, is that some of our service users are being readmitted to hospital because interventions or the support that NHS offers, particularly after COVID, became very limited. I don't know what experiences you guys have, and how do you approach this situation? Would be interesting to listen to.
Thanks, Pedro. Natalie, I think you wanted to come in on innovation.
Sorry, yes, it was just, sorry, Pedro, I will go back to your question, but I think what Maggie was saying earlier about the importance of understanding the role of the RAs and support workers. For us, we're spending a lot of time educating MDTs as to the need to integrate the support and rehab into the teams as well, and making sure that they understand that they are such an important cog. I mean, sometimes we have MDT meetings that happen without the RAs, which shouldn't be happening. They need to be part of it. And for us, what we found has been really useful is to kind of getting the fire in the belly of people coming into the industry and the RAs to be really excited about working in neuro and realize that they're making massive differences to people's lives. And that needs to be felt by them working within the MDTs as well, so that they're not kind of just an add-on, that they're actually a respected member of the team and an important member. So they feel that they're part of it. They feel that they've got that level of respect. And we've had to do, sadly, quite a bit of education around that, both when we train people coming in that potentially they might find challenges within MDTs and how they're integrated, but also with the teams and the case management and therapists to ensure that that level of mutual working is there. So for us as well, we don't just bring in RAs that just work with clients. We get them involved in every part of the organisation. We get them involved. We get them working on research and development of the organisation and doing articles and things like this to make sure that they feel that it's important part of this world of neuro rehab to, again, make sure that they've got that drive and fire in their belly to want to continue it longer term.
Thanks, Natalie. Just moving on from, sorry, Sarah, did you want to come in and give some examples of innovative ways that you're overcoming these challenges?
I think what it is that as an inpatient rehabilitation provider, that we have a level of responsibility in the rehabilitation we provide to enable it's a very, what's the word I'm looking for? A well-known therapeutic route is to be able to grade activities to enable the patients to be able to take on more responsibility for themselves in everyday living, and by doing that do our very best to prepare them for the community, but also offer those vocational opportunities. And opportunities, we had one of our patients just over this weekend actually go to a football match down in London, and you could imagine from a rehabilitative perspective all the various levels that were going on, but he himself had that end result of a meaningful activity. But what we do and find to be very good, and there is, in fairness to community services, there is a real push and there is a desire to get people from inpatient services back to their home areas. And we work with teams. We may have members of their team come in and actually spend periods of time with our patients, actually, so they are in vivo experiencing what the patient's life is like and picking up how to work with them. But then we have really seen that the community teams are really putting together to try and ensure that you have a psychiatrist, a neuropsychiatrist, where you have the OT, the speech and language therapy, and actually the involvement of the family in planning what that special package might look like going into the community. So although it's not innovative, what I would say on a very positive note, there is a real desire to get people from inpatient into the community. We've just got to make that successful for the individual involved.
Yeah, that's really helpful, Sarah. Stephanie?
Sorry, I couldn't find the mouse then. I think an area coming up that's going to be help with innovation and will be interesting to see how it progresses is all around AI and what that's going to bring in terms of some robotic help, how accessible that's going to be, and all the challenges that come with that. I think that's going to be interesting as that develops over the next year or 6 months as that comes through. And I think I agree with Sarah. It's all about, and it probably doesn't sound so innovative, but asking the person what's important to them. So rather than the focus, which can be on getting home, as to going to that football match and being with their friends and having a drink is far more important. So how you build then the other therapy goals into that activity, that's what we do. That's the bread and butter of what we do and what's occupational therapy, and I think is going to need to be more and more going forward.
Great examples, Stephanie. Maggie?
Just to say that it's good because CQC, who register us, and any clinical case managers that are out there working, and some therapists obviously have CQC registration as well, depending what service they're doing, are looking now very much at what the client wants, so that from day one it's all about their wish list, which is fantastic. I mean, it's what we should all be doing anyway, but it's great that they are putting all of that to the forefront with their inspection of nursing homes, of case management companies, of agencies, and that things are changing and they're becoming much more person orientated, and that, which is always a good thing, really, rather than it just being bureaucratic, because surely that's going to also have an effect. But I agree about AI. I think it's fantastic. I mean, you look at Japan, some of the stuff, you can press a button, you can transfer from this to that, another piece of machinery. I'm hoping to go out to the Arab conference in January next year, because apparently it's amazing what they're doing in Saudi Arabia. They're doing stuff we'd never seen, and of course it's all going to come. So I'm quite excited. I've been quite negative about it in the past, saying, oh, we need people. Of course we need people, but we're not going to have the people. We're not going to have the young. There's going to be a huge problem with the elderly. So the more we can do that's dignified within, and Japan has shown that, because dignity is very much their thing, very much privacy. And so they've worked some amazing machinery around with personal care and stuff. So I'm quite excited, you know, new things. We'll see what happens in the next few years.
Thanks, Maggie. I think there are probably two discussions that we need to have in separate sessions. One about people, the points that you were making, Natalie, and Maggie and Stephanie. I'll look at technology and AI and the impact that will have. So I'm sure we'll try and organise separate roundtable discussions to look at both of those areas and dig into them more deeply. I'd like to sort of pull the threads of this discussion together now and go around the panelists again and ask each of the panelists about their outlook, looking towards the future. For each panelist, what are your hopes about those things that you would like to see change during the months and over the next couple of years that will make a fundamental difference to care and support in the community? And it may touch on Stephanie's point. Stephanie, you said that it's difficult to influence governments, which of course it is, but are there external forces that you would like to see changed in some way that would make a fundamental difference to the sector? Or maybe it's about innovation and technology. So just a very brief thought from each panelist about looking towards the future, what your hopes are for the sector and the impact that it has on your clients and in those people that are living with the need for care and support. And I'll start again where we started with the introduction, Sarah, if that's okay, and come to you first. I think you're on mute there, Sarah.
From my perspective, I think it is very much about when people are ready to leave inpatient services, that we are timely in the journey that they take from here going into the community, and being able to have that understanding of the level of mentorship and coaching that that particular individual needs. And I think what's quite clear is there is a difference between those that maybe come through case management and private to those that actually are cared for within the NHS and the public sector, and to be able to see a little bit more parity of esteem between those two provisions, so that we have got the strength of those that have come in for other reasons other than, you know, through the private sector, to be able to go and live the best life that they can do, and to be able to have, I suppose, equal opportunities. A really good example, you know, just in brief, is, I mean, we can have an individual who has got compensatory payout, and they can have the most wonderful wheelchair that will enable them to go into the world, to be able to interact and do what they want to do, and it will have, if you like, electronics to be able to do that. You take that for somebody who doesn't have that, and they will have an NHS prescribed wheelchair that doesn't have any electronics, and so therefore it is very hard. That individual needs to have somebody else enable them to go into the community and to do things. And I think somehow being able to look forward, and whether it's about more charities, whether it's about more private funding, to be able to perhaps bridge that gap between the two, I think would be it would be good to see that kind of driven forward.
Thanks, Sarah. Jane.
I think three things. The first thing is, as a sector, we should be doing and contributing to more lobbying of government to address these resourcing issues, which we've all identified in different ways, for people's right to statutory help at the right time when they're discharged from hospital into the community. That's a big project. And there are some organisations which are out there really helping to focus that, and we should sign up to it and support it. But in terms of some very practical things now and over the next few years, I just wanted to focus on two, which is again making use of some and supporting the development of some excellent online technologies. AI and ChatGPT and all of those things may be part of it, but there are some really good platforms in development at the moment, and I'm just going to give a quick plug to one called NewMind, but there are others as well, where a particular app effectively for clients can be used to actually bring all of the communications around the case together, so that information is very accessible from wherever it's coming, whichever team is involved, NHS, private input, and so on. And it's gathered together in a really accessible way that facilitates excellent communication between everybody involved, and of course with the client at the centre of it. So that's one thing I would really like to see and expect to see developing over the next 2-3 years. And then the other thing is going back to the staff pipeline. Others have made the point as well. We need to have more therapists in all of the disciplines. I would say currently our experience, especially there's a shortfall in neuropsychology and speech and language therapy. Yes, let's work with universities, let's work with health providers and commissioners to support attracting more people to those disciplines. Let's work with providers like Natalie's to really engage the interest of students in psychology or other disciplines who want those careers, and let's give them the training opportunities within our own organisations that will allow them the rewards of working in this tremendously uplifting area when we can get everything right. And just as a parting shot, if there are therapists out there who are keen to supplement what they're doing in the NHS, coming to work in a really joined up team like ours, we'd love to hear from you.
Great. 3 great points, Jane, and a good plug at the end as well. Pedro, your hopes, things that you'd like to see change now, looking towards the future.
Staffing to support our service users is quite a key factor for their rehabilitation and safe discharge to the community. We are a residential service, but when we talk about community, it's about independent living. So that is quite a key point for us. Liaison with the community services. We, for example, when patients are discharged from hospital, there is no liaison between inpatient or hospitals and residential services. There is a break. Communication is not maintained. That impacts on service users. So that is something quite easy that can be addressed. Funding, housing is quite difficult as well. So for us, these are the main areas where we think we should be focusing more our energy in terms of being able to move forward and support the service users.
That's great. Thanks, Pedro. Natalie, same question.
I'm going to echo all three at once. Everyone's saying what I was going to say. I think, yes, we need to make sure we've got this pipeline of individuals wanting to come in so we don't have this shortage. Again, going back to what I was saying, kind of getting the fire in the belly of this being a really important industry to work in. And I think it goes back to all of us as well, making sure we're raising awareness globally about brain injury and the needs of individuals to everybody, not just those that are working in it. We can all be doing more of that, certainly. I like going into schools and getting them before they've even gone to college, talking about it at a much younger age to raise awareness and to get interest that there are so many different therapies that people can go into. When we go to careers fair, we talk about how computer science students can come up to us and we talk about the tech and what they get into in robotics, things like that, just getting that interest up there. And putting my trustee hat on, I think certainly there's a lot that can be done within the medico-legal sector to aid funding for charities. I don't think we do enough of that. Certainly our smaller headways that struggle. And there is a big disparity between the understanding from the medico-legal sector in terms of how they can support it more and how they can signpost people. There is a big gap there that I think we can all do more for. And I think, just echoing what the others said in terms of getting more people in. They are there and they will stay. We've just got to make it fun and interesting.
That's great, Natalie. Thank you. And I'm conscious that as we go around the panel, it's hard not to come back to the same themes, but I think it's helpful to do that because it reinforces those themes are very common across the care and support services that we're talking about. Stephanie, your thoughts?
So my focus is on the therapy side and having functional rehabilitation that focuses on people regaining function and learning new skills to reduce care needs or amazingly remove the need of it if at all, if possible. And I think there needs to be much more of a focus on that because we can't control what's happening to some degree out there in the wider world. And I absolutely agree with everyone that we all need to be supporting and getting along with the campaigns and becoming a much bigger voice because that problem is only going to get bigger. As I said earlier, I'm really interested in AI and technology, but there's also that bit of me that worries that is that just going to shift the problem? So if we have a generation or a group or population that then becomes reliant on robotics doing everything for them and all their care needs and everything can be maintained at home, how are they then going to live their very best life and do the things that are important for them? What roles are we going to have in the future? I can't think of anything worse than being confined to my home, everything being done for me. I'd probably quite like the cleaning done, but everything being done for me. And then what on earth do you do with the rest of your time? So I think as exciting as that is, there's also some challenges that we need to be kind of ahead of and thinking of ahead of that. And it's always, for me, comes back to that restorative rehabilitation that focuses on function, focuses on enjoying life and participating in roles and responsibilities.
Thanks, Stephanie. Loud and clear. And Maggie, you get the final word. Thoughts and hopes for the future?
Well, we're short of time. I can see we're running out. All I can say is it's got to be about upgrading the image of support staff, upgrading their role, making sure that it is a career move, making sure that we make the most of that so that we actually do attract the right people. There's going to be such competition for these people in the future. So it's really working on that now and not leaving it till it's too late.
Great, thanks, Maggie. And I wish we did have more time because it feels as though we're just scratching the surface, but we've covered so much ground. I think it's been a fabulous discussion. So on behalf of NR Times, I'd just like to say a very sincere thank you to all of our panelists for being so generous with their time, their experience, and of course, your views. I think it's been an incredibly positive discussion as well. So for everybody watching, firstly, thank you for watching and giving up your time to do so, but please share the link in this discussion as widely as possible. I think it deserves to be seen by the greatest number of people. I'm sure we'll come back and address some of those subjects in more depth that we touched on, particularly around people and skills and the role of technology. So I hope everybody's enjoyed watching this NR Times roundtable and the outlook for community care and support. We'll stay in touch and please stay in touch through the NR Times site and let you know when there are going to be future discussions taking place. But I'll just close this discussion by saying thank you once again to our fabulous panelists. Thank you.